PhD in clinical community psychology from the University of South Carolina and specialized in health psychology. An epidemiologist at the Centers for Disease Control and Prevention, she worked in Sierra Leone as part of emergency response. She now directs research for the Chronic Disease Prevention Division at the Philadelphia Department of Health. She founded and directs the 501c3 Welbodi Sierra Leone, which provides comprehensive high school scholarships for girls to help Sierra Leone rebuild after the devastating epidemic. Please welcome Hannah Lawman.
Working before.
It's no signal. Okay.
You can leave the lights on. Here we go, Richard.
You'll put the lights in.
Thank you so much for having me. I'm really excited to come talk to you. I think really what I see my role today is more in asking questions. I don't really have any answers. So I'm really interested to kind of just share with you my experiences about working in Africa on the emergency Ebola response and kind of ask some questions that we can grapple with together and think about what it means for the path forward. So I volunteered to go to Sierra Leone during the emergency response in the Ebola epidemic when I worked for CDC. My work focused mainly around behavioral change in the communities there, trying to help them understand the things that they could do to protect themselves from Ebola, to prevent spreading of the infection, and to really try to help us get to zero. So I worked primarily on a project called the Ambulance Project because there was a great fear about ambulances in Sierra Leone because of the Ebola epidemic. So they had never really seen ambulances before, and then all of a sudden ambulances start coming in, taking away their loved ones, and their loved ones are never seen or heard from again. And this was commonplace in the height of the epidemic. There were hundreds of cases a week, 400 cases a week, and there were just not enough resources to be able to control the epidemic. People would never hear from their loved ones again. They wouldn't know what happened to them. They wouldn't know where they were buried. And understandably, this created a lot of fear, and there were a lot of myths around ambulances themselves causing Ebola. that the healthcare workers were killing people or infecting people with Ebola, that there was a button in the ambulance that they would push to flood the ambulance with chlorine water and kill you, that nurses were injecting you with Ebola. There was all kinds of myths around the ambulances. And so my work tried to take a very community-driven approach to showing them that the ambulances were not something to be fearful of. So we had a whole team that went around, and this is kind of after the worst of the Ebola epidemic, when cases had kind of died down to a more manageable caseload. And this allowed us to kind of put more thought and attention to some of the community concerns and more novel and community-based ways to address those concerns. So I kind of have lots of pictures behind me that you can see from my trip and the work that we did there around the ambulance project, and just the strength and resilience of the people in those communities there. So a little bit of Ebola 101, because I'm not sure everyone is on the same page with that. Ebola is actually very difficult to contract by kind of Western hygiene standards. You have to come into direct contact with bodily fluid of an infected person, and the key part is that they have to be showing symptoms. So someone who's still in the incubation period, that 21-day incubation period, who was infected but is not symptomatic, cannot infect someone else. So if someone has a fever, if they're looking sick, you keep a certain distance and practice hygiene and infection control practices. So it's actually fairly difficult to contract by Western hygiene standards. There's a very high death rate. So death rates in some places for Zaire, which was the strain in West Africa, are as high as 90%. 90%. The death rate that we see right now in Congo is around 60%. And these are based on very poor figures. The data tracking is a little difficult there. But the very early stages of the disease look very much like something that they deal with on a daily basis, that they have been dealing with on a daily basis for generations, and that's malaria. So fever, headache, vomiting, those kinds of things at the beginning is how Ebola manifests. It doesn't often even get to the stage of blood that people think so much about. So it's very different from their perspective for Westerners, oftentimes, or outsiders from their village to be coming in and telling them to treat their sick in a different way than they've always known how to do, or feel comfortable, or is dictated by their cultural and religious practices. So a lot of the ways that Westerners were kind of dealing with the response created community resistance, and maybe it was not the most respectful way and considerate way of dealing with the response. So the Ambulance Project tried to take a different approach and really engage community village leaders. So you can see in some of the pictures that there are village chiefs who actually went out and took a ride in the ambulance so that the village chief could see that there was no red button, the ambulance was safe, it even had air conditioning. And we kind of addressed a lot of other fears and concerns that the communities had in a way that showed them that there was nothing to be scared of, rather than just having community meetings and telling them there was nothing to be scared of. We actually let them take rides. We washed our hands, and the community took place with a community hand washing with chlorine water to show them that the chlorine water was not harmful. There was even skeptics who said, oh, that's not really chlorine water, that's not what they use. And we had our wonderful community-based staff who said, try it and smell your hands. You'll smell. They smell different. So our team started by doing it, and we had the village leader come and engage in that community hand washing, and then everybody in the community could come and actually wash their hands and have that experience themselves, that the chlorine water didn't harm them. And that was what was used to prevent the spread of Ebola. So it was a really enlightening experience, having, going to a country like Sierra Leone in one of the most difficult conditions that, times that their country has ever experienced, right when they were recovering from their civil war. Their civil war had just ended, and they were just starting to grow a tourism industry, just starting to kind of recover a little bit, and then Ebola hits and spreads like nothing we've ever seen before, in terms of this kind of an infectious disease. In the end, it was over 28,000 people in West Africa, in Sierra Leone, and Guinea, and Liberia that were infected, and over 11,000 people died. It took more than 2 years to stop the spread, to contain the infection, and they lost a significant number of their healthcare workers and healthcare staff. Those were the frontline workers, and they were the ones being exposed and suffering very heavily as well. So, what does that mean for tomorrow? For the next stage that the country is going to have, and being able to have their healthcare needs met, and other needs met as well. Our ambulance project was really exciting to me in several ways because it was really community-led, and we had folks from the village who were leading. It wasn't a Western-led effort. It was, we tried to stay in the background and provided resources and support for the community folks to do what they do best and connect with their fellow community members. So that was really exciting to me. Abbas is the guy who I worked most closely with on the ambulance project. He kind of coordinated all of the local responses and coordinated the team members. We went to 36 villages with the ambulance and the team kind of going around and talking about the ambulance. And it was a really exciting project to see hearts and minds changing in a way that was needed at that time. And in a different kind of way of responding to the epidemic than we had been using in the past. And the height of the disease over in West Africa, like I said, they were seeing 400 or 500 cases a week. But when I was there, it was, 5 to 20 cases a week. So it was much more manageable, and it allowed time to do things what I might even label as the right way, rather than just kind of being so reactionary to all of the cases that were there. So, this experience highlights a lot of ethical considerations for me, a lot. There are 4 that I kind of would like to focus on. One is the timeline of the U.S. intervention, Western intervention. When did the U.S. get involved? When did the U.S. start dedicating resources to go over and help the West African Ebola epidemic? It wasn't until 9 months after the first case, and it was 6 months after the WHO put out the report that there was Ebola there. At that point, almost 1,000 people had died. And that was when the U.S. decided to intervene. The other prompting event around the U.S. deciding to intervene was when Ebola came here to the U.S. And there was the first doctor from West Africa, from Liberia, who went to Dallas, Texas, and was discovered that he had Ebola. He was the only fatality in the U.S., and the 2 nurses that took care of him ended up contracting Ebola as well, and they recovered. But the timeline of the U.S. intervention raises a lot of ethical questions for me. When is the right time to intervene? Is it only when the U.S. is threatened that we actually start dedicating resources to help people that are really suffering and have been suffering for 9 months at that time? So the timeline of the U.S. intervention is one of the big questions, and really the larger international community as well, not just the U.S. A lot of folks were quick to criticize WHO for waiting so long to declare an emergency, which opens up more resources. So it prompts a lot of questions around, when should we be intervening? Another ethical consideration that I struggle with a lot around the Ebola response is how and when and why vaccines and diagnostic tools are developed. There have been outbreaks of Ebola for decades, since we have been tracking them from 1976 to 2014. There have been a total of 1,600 Ebola deaths in all that time. Each time a new outbreak would surface, there would be a lot of attention and interest around a vaccine that would then peter out because the threat would die down, and then the urgency around developing the vaccine would also wane. So the vaccine that we have now, that is possibly the number one reason that we don't have another West Africa emergency response in Congo right now, the vaccine that we have now, we actually developed 10 years ago. We developed it, it was developed by the Public Health Agency of Canada and the U.S. Army. We had it 10 years ago, but it hadn't, reached a stage where we knew that it was safe or effective and couldn't go through the process that we needed for vaccines to go through. In part because Ebola outbreaks were quite rare. Only 1,600 deaths in 40 years. It's hard to test under those conditions. But once it became a threat to the international community that might have more money, to be able to pay for a vaccine or to be able to pay for the research to get a vaccine, that's when we started seeing movement around trying to get a vaccine, when it became such a big problem. But thousands and thousands of West Africans had to die first in order for us to really make movement on a vaccine, and that's something that I struggle with a lot. So, we currently now have a vaccine that is approved for use as compassionate care. In Congo, it seems to be very effective, 88 to 98% effective. So, that's very promising. And there have been over 100,000 people in Congo that have been vaccinated this time around. And it's very effective when administered early. So that's, something that we're excited to have now. But also makes you question why it took so long to have it, especially, when we had some version of the current vaccine 10 years ago. Did 11,000 people in Africa have to die for us to realize that we needed to develop a vaccine or other tools? One of the things that was really hard when I was there is people were very scared to get treatment because they saw so many loved ones leave and never come back. So they didn't want to go to Ebola treatment centers. And that was understandable because when there was a lot of cases, it was not uncommon for people to go to the Ebola treatment center because they had a fever, they had symptoms, they get tested at the treatment center. It takes a day or two to do the testing to confirm whether or not it's Ebola. The testing comes back negative, the person is released, and then days or a week later, they're back and they have Ebola. And chances are they got it in the Ebola treatment center being exposed because the treatment for and the infection control and the resources available were limited. So people had a reason to be scared of treatment as well. What would it have looked like if we had a diagnostic tool where as soon as they had a fever or other symptoms, we could test right on the spot and tell them whether or not it was Ebola? They don't ever have to go and be exposed to people that have it and increase their risk of contracting it. So this is a tool that they're working on. But what's the implication for the technology that we can develop, that we should develop to save lives? But it's hard, or there's other constraints around that. So when and why and how should we be developing vaccines and diagnostic tools and other technologies to help us save more lives there? Why Ebola? They have been dealing with malaria. Malaria kills a lot more people every year. Why is the West suddenly showing up now that Ebola is around? This also kind of sparks some distrust and resistance, and it's confusing, understandably. Why are they showing up for Ebola? But people have been dying for decades from malaria at astonishing rates, and there's limited response around that. Of course, we know Ebola is much more infectious, and the death rates around Ebola are concerning, and we want to keep it from spreading. And the disease operates differently than malaria does. But from their perspective, it's, why are you showing up now? Which is a good question. So that leaves us with a lot of questions, to think about. And the third kind of category of ethical considerations that this whole experience prompted for me was, what does an ethical response look like? I am excited about the work that we did around the ambulance project, but what does it mean for us to listen to the community leaders and to recognize their experts and to build their capacity so that they can be involved in the response and trust in the response? For it to not be outsiders coming in, taking over, acting like the experts, to respect their burial practices in a way that also helps us control the disease, to understand their concerns around ambulances, to respect their cultural practices around traditional healers. So they have always treated illnesses with traditional healers, salves and herbs and massaging and those kinds of approaches for treating illnesses is what the villages are used to, and that's what they have access to, and that's what has worked for them for a long time. But for Ebola and infection control, they were a real problem in Sierra Leone and in other countries in Africa too, because those kinds of treatments were killing traditional healers and spreading Ebola. So then you have a real quandary when telling them not to do these very culturally, spiritually important practices because of Ebola. So how can we create a response to Ebola that is more culturally appropriate and that recognizes the things that are important to them? I think that's a real problem with Congo right now. A lot of the challenges around the response are violence perpetrated against health centers and healthcare workers, resistant, being seen as outsiders, being seen as political agents. So there's this real need for conducting a response in a way that respects those cultural practices and their expertise, to really, in the end, get a better response and maybe a more ethical way to respond that kind of respects those cultural practices and traditions. The burial practices that they engage in are very important. Washing of the body, preparing the body for burial, certain practices around how they bury their dead. When Ebola hit, all that went out the window. They wouldn't even know where their dead were buried. So how can we create a response that is more considerate and inclusive of what's really important to them? And I think in doing that, it'll help us create a response that doesn't generate as much resistance. as we saw in West Africa and as we're seeing now in Congo. And then for me, the part that I struggle the most with to this day is what do we do more broadly around the infrastructure that they need to support health and education and help them grow out of poverty. So in a lot of ways, a lot of these problems with the response and with the spread of Ebola can be linked to poverty. So what is our role as Westerners who have a certain standard of living and who like certain things? What is our response and what is our responsibility now to help support them in developing more infrastructure, in pursuing education, and generating more capacity to be able to deal with these kinds of challenges themselves? So it's been hard for me since coming back to even buy things, because having seen firsthand how far an American dollar goes in Sierra Leone and what it can do has been really, really hard for me. So that's kind of a question that I struggle with, and maybe is the one that we have the most potential to do something about. Maybe some of you are on the verge of developing the next vaccine, or know someone you can call in the U.S. government to tell them to intervene sooner. But really, this is also the part where we have the most power to do something about it, to help support a lot of the efforts to advance healthcare and education, other things that we know work to reduce malaria, and other things, not only thinking about Ebola and something that impacts us or has more potential to impact us. So what can we do now? What does American consumerism have to do with what we see people in Africa struggling with every day? You'll see a lot of the kids in these pictures, they don't even have a shirt without a hole in it to wear, or shoes. So they are struggling. The villages that we went to don't have running water. They don't have electricity. They're facing some real challenges there. And what is our role in fighting that? And in doing that, we build a stronger Sierra Leone that's more capable of weathering something like an Ebola epidemic. But it's really up to us to kind of proactively help build that infrastructure and not reactively address it when it threatens our safety. So that's I think the one that I struggle the most with today, and what led me to try to continue to do what I can to help the people of Sierra Leone in a very small way. So I'm now very self-conscious of giving such a downer talk on Mother's Day. So maybe I can wrap up and end with a little more inspiration, which is, we're trying to send girls to school, to help them get an education, to help provide that kind of infrastructure and response that Sierra Leone needs, and that we need all Americans to think about what can they do to support the people, not just in Sierra Leone, but really in developing countries, undeveloped countries that need help. And they need help in a dignified way. They need help in a responsible way. And so, there's 30,000 orphans in West Africa because of the Ebola epidemic. There were kids that missed an entire year of school. You have a generation that missed an entire year of school. And routine vaccinations for issues that we have vaccinations for, those declined during the epidemic. So we're going to have a lot of these big questions that we're going to need to ask ourselves as a society, how we're going to respond, and as an individual, how we're going to respond, what we can do. For me, starting Welbodi Sierra Leone, Welbodi means healthy in Creole, which is the language there, a common language in Sierra Leone. So what can we do, even just a little bit, that can save the life of someone else and make an impact, and help this beautiful, strong, bright, ambitious young girl grow up to be the mother that we're all grateful that we had or wish we had, that the mothers that we are recognizing today. So that's, part of what I'm seeing as my role and what I want to be able to continue to do today, having now, come back several years later. But what does it mean now for us? We don't see these kinds of pictures every day. And part of the reason I'm so passionate about it is because I saw it with my own eyes. And I saw what a dollar could do and what it means to them and their strengths and how resilient they are as people to all kinds of everyday poverty challenges as well as those challenges that Ebola brought to them. So it's really hard when we aren't able to see it with our own eyes and experience it with our own hands and see what it looks like and what we can do. So that I think is another question that I struggle with. Like, how do we help people understand that they can have a role as well? So, this is obviously most relevant now to the outbreak in Congo. So currently there's been 1,600 cases in Congo, 1,100 deaths. The real challenge with Congo is the political instability and the violence. Their response workers are being attacked. CDC is not allowed to go into Congo because of safety concerns. They're in the surrounding countries trying to protect against spread in the surrounding countries. But what lessons can we learn from the West African epidemic, both around when we intervene, how we develop vaccines, how we conduct an ethical response, and what we do after the fact? What do we do now to help them build capacity to prevent something like West Africa happening again, and to stop it in Congo now, or the next Congo. So, like I said, I have lots of questions and not a lot of answers, but just some of my experiences that I wanted to share with you, and really how they continue to impact me today. When you see some of the things that are happening over there, it really touches you and changes you in a way. So hopefully today I was able to touch and change you in a small way too, to show you a little bit of what it's like over there and what you can do to help stop the next West Africa outbreak. So I don't know where I am on time, but a few more minutes. Okay. So let's see. I can kind of tell some other additional stories that kind of illustrate some of these points that I've been making, and maybe that you see in some of these pictures. So a couple pictures ago, you saw a family standing in front of a blue line, a blue string. And that was when we were there, that was how we placed families in quarantine. So there was a string, it was a symbolic barrier, not an actual one. This was in a village where we couldn't figure out who in the village was exposed. So the standard epidemiological response is to figure out who was exposed and to quarantine them, who was a high-risk exposure, who else may have been exposed, and monitor their temperatures for 21 days, which is the incubation period. So in this village, we couldn't figure out who was exposed, and people kept dying that we didn't have on our list. So the community was having a really hard time trusting us and telling us who they came in contact with and how. And what we ended up having to do then was to quarantine the entire village because we couldn't isolate, where the families that were most at risk were. So one morning, when we were doing our routine morning temperature checks, there was a woman who was missing. And this woman was a little person, and this was probably about 10 o'clock in the morning, and the lead agency, who was UK's aid agency, said, who's out looking for her? Where is she? She was in a house that had had a couple of people die from Ebola, so we thought that she was infected and showing symptoms. And the whole response there said, oh, we're not looking for her. It's very well known this woman is a sorceress. And she turned herself into a snake, and she's out in the woods. So, we don't need to look for her. There's no use looking for her. And this was the actual response workers there. They believed this was their beliefs. And without missing a beat, Brenda, who was leading the response from the UK and leading the quarantine of that village, she said, all right, we need a spiritual response and we need a physical response. We got to cover both of our bases. So we organized the spiritual response to combat the sorcery and to get the religious leaders and the village leaders in there to do the religious ceremonies that would help find her. And then we also, just to be safe, had a physical response as well, where we actually had people out looking for her. So this is a story that I like to tell to illustrate another way that Western priorities and their cultural and religious priorities don't have to be at odds. And we can think of a response that is more respectful and considerate in what they value and want to see. And so, that they don't have to be at odds. And the response, a lot of what we've learned from social science and can help us in thinking about a more ethical response, so that we know how to react in those situations where it's just not a scenario that we think of from a Western point of view, or that we would value from a Western point of view. So that's an example of what I like to call what a snake can teach us about a response, an Ebola response in Sierra Leone. So it was a challenge, and figuring out how to overcome the community trust issues and value issues. There were lots of challenges that way. So it was really a life-changing experience, like I've said before. And there's lots of other stories around ethical and cultural ways of responding that I would be excited to share.